Okay, so we have lots of questions we could address to the panel. Some of the radiology ones, we don't have our radiologist here, Dr. White, but she had to leave, but all of us are very familiar with these things and can talk to most of these issues as well. The question is, how long can a patient be progression-free after trans-arterial embolization or chemoembolization? And that really varies tremendously from patient to patient, but it's often a year and a half, 2 years, it varies, but it's not a forever and ever treatment in most people, but sometimes it can last for many, many years. Tremendous variability, but if you just average it all up, it's usually somewhere in that neighborhood. Anybody have any other thoughts?
This is how long they last? Is that the question?
How long does the effect last?
Yeah, so the progression. So if you look at the literature, it says 12 to 18 months. That's classic. Our experience when we continue everolimus during the embolization, we get out about another 6 to 12 months. So we're seeing at University of Kentucky somewhere around north of 28 months. So we've added another year to it. So we've had some people that'll go out more than 5 years. We've had some people that obviously don't quite make it 28 months. But the problem with chemoembolization is they stop all the systemic treatment except maybe octreotide or lanreotide, and then they give the chemo locally, or they really don't do that anymore. You know, with they give the Lapidol or such, but the beads are gone. You know, the beads are too toxic. So it's really just a blend, and that's pretty much what I started when I was in New Orleans, was just do blend. And once I've gone to Kentucky, I've never done a chemoembolization for the last decade, never a chemo.
Right.
So I just have the oral drug everolimus going. You just don't stop it. It doesn't really block healing at all.
Right.
It doesn't suppress the white cells or the platelets.
We've been doing bland embolization also rather than the other varieties.
To have some sort of systemic agent.
Yeah, except for people who are on that the clinical trial. Okay, there's one
can I add
easy
one more
pathology
thing?
question I'll just
can I add one more thing?
Address.
So I want to add one more thing. Just don't forget about other extrahepatic progression. Like, don't concentrate only on the liver, because the disease can grow anywhere in the body. So don't think like, okay, for 1 year I'm only going to get CT scan of the belly, but I would say full scans with the treatments.
Okay, there's a pathology question. What is MANEC? M-A-N-E-C. MANEC is an obsolete pathology term, which is basically the same condition as what we now call MINENS, mixed neuroendocrine tumor, which we heard about, I believe, yesterday in the pathology discussion. So it's really the same thing. It's just that it used to be called MANEC instead of MINES, but don't worry about it. Okay? We have a couple of questions here on PET scans. And several people wanted to know, how come I never got a regular PET scan? I only got the gallium dotatate PET. If you have a tumor that is slow growing and has a low metabolism, the FDG PET, fluorodeoxyglucose, which is a measure of sugar metabolism, that scan is usually negative, okay? Because the cancer's not eating a lot of sugar, so you can get a gallium dotatate PET, which is a targeted neuroendocrine cancer based on somatostatin receptors. So you really don't need the FDG scan at all. There are only certain circumstances where the FDG, regular PET, is appropriate. And those are mostly high-grade neuroendocrine tumors, or questions where there's a question about some tumors potentially progressing or growing and being negative on gallium dotatate, and you're trying to make decisions about PRRT where you get both. But you don't need to do both. And the fact that neuroendocrine tumors don't live on sugar and don't have a positive regular PET scan should also tell you that you have a lot more things you could eat, since cancers are not being driven to grow by sugar. So if you want one of those chocolate chip cookies outside, not that I'm recommending chocolate chip cookies instead of healthy food, but they're not going to be like poison to your cancer.
I can add something to that. So just to summarize so PET scans that we use for other cancers, basically the way they light up is they light up in areas where cells are rapidly replicating. So for example, in somebody with a high-grade neuroendocrine cancer, those cells are rapidly replicating, so it's more likely that your a general PET scan would light up because it's showing areas where cells are rapidly replicating. The dotatate scans, the gallium scans, scans that are specific for neuroendocrine are really specific for the hormones. So it's a very different way of looking at the cancer cells, and that's why a regular PET scan isn't going to be as effective in somebody with a neuroendocrine, especially a lower grade neuroendocrine, because it, as our fantastic moderator mentioned, it's not going to light up there. I'm just going to throw this out there. I have a flight to catch, so I am going to duck out at 4:50. So if you see me sneaking off, it's not because I don't want to be here. If I miss my flight, it will be a very bad thing because there aren't very many flights out of Atlanta.
While
late
you
at
have
night.
the microphone, there's a question
Sure.
for you here. Do all NET centers have a NET surgeon on staff? How do we know they have experience? And is there a fellowship program for NET surgeons?
That's a great question. So NET surgeons, every hospital and every academic institution does not necessarily have a NET surgeon on staff. That being said, there are surgeons, surgical oncologists and general surgeons and surgeons in specific fields, endocrine surgeons, who are very adept, depending on where the tumor is located, at removing the entire tumor and being very effective as long as they work in a multidisciplinary approach. So just because your surgeon isn't a neuroendocrine surgeon, that doesn't mean you're in the wrong place. Just make sure that your surgeon is communicating with the oncologist, with your endocrinologist, with whoever else is involved in your care. I think that's more important than anything. And then ask your surgeon, how many of these have you done? Have you seen neuroendocrine patients? Do you manage neuroendocrine patients? What's your experience with neuroendocrine tumors in this particular location? And if you don't feel comfortable, you can always ask for a referral for somebody who might be doing more of these surgeries, especially if you're in a center that may not see neuroendocrine tumors that often. But you don't need a neuroendocrine specific surgeon to be a very effective and great surgeon for you.
Right. In some centers, liver surgeons take the lead in doing aggressive surgery for removing carcinoids. In other places, it's surgical oncologists. In other places, it's the two surgeons working together in the operating room. The main thing is they should know what they're doing, have a lot of experience with neuroendocrine cancers, and understand that this is not like treating horses. When you're treating zebras, you want to do maximum cytoreduction, and things that otherwise might be considered inoperable are actually operable and can really help people tremendously. Yes?
So just a final comment between the FDG and the dotatate scan. I see this in eras made when a radiologist reads out a dotatate scan. If they use the word metabolism, they don't know what they're looking at, because you see it.
Oh, yes.
And it's very frustrating because it tells you at that center they really don't know what the dotatate scan is. It's not metabolism. We're looking at the expression of the somatostatin receptor. So the word avidity, A-V-I-D-I-T-Y, is one that Dr. El Cooley, who you heard yesterday in her report, she talks about avidity. And so when the word avidity comes up, that's a tumor. And I mean, it won't say a tumor, avid tumor, it'll just say avidity. But if you see, in a regular PET scan, they say the metabolism, the metabolic index is higher. So it's measuring totally different elements of the cancer cell, or the tumor cell.
So I want to give a last comment and ask Dr. Anthony about his experience with that. So yeah, in general, we get the FDG for the high grade and the G3 well differentiated, and the PET scan somatostatin receptor for grade 1 and grade 2. How about the couple of presentations that we have at last NANETS and ENETS talking about get a PET FDG and PET gallium-68 or copper-64 for the patient who are going to have PRRT, especially grade 2 Ki-67 10 or more. Do you do that routinely at your institution, or do you recommend something like that? Like, do you do both the PET scan, the FDG, and the gallium-68 for PRRT if the patient have a grade 2 Ki-67 10% or more?
So, so we usually, the pathology dictates it all. So we would love to get the FDG at the same time that we get a dotatate for the grade 2 patients, and for obviously the grade 3. But the dotatate will really kind of direct what care would go for a PRRT. The FDG, probably not. Unless the receptor expression, you have to really look at the difference there. But you can, on FDG, you can have the dotatate expression, you can have somatostatin expression. And there's the work done at Memorial Sloan Kettering, they've actually published about 19 patients where they've given PRRT to those high-grade patients. The problem there is the patients are really beat up and they don't get through four cycles. They got through about 2. So it can have some benefit. It's short term. They only benefited for about maybe 3 or 4 months. It was a very short term. There needs to be more studied in the high grade. I'm not sure pharma is going to get behind the real high grade, the carcinomas, but we'll have to work. We've got some thoughts about how to approach that, but it's not easy.
Right. A valuable comment about FDG PETs and gallium dotatate PETs together at the NANET session.
Yeah.
One of the biggest problems I can tell you is it's very, very difficult to get insurance approval for a second PET scan, especially in the same time period, which is what we're talking about. So
And
you have to be very careful about which one you choose.
But FDG PET is more prognostic. Prognostic is a word we use for indicator of how aggressive the cancer is. Not sure in this day and age it's predictive, which means it can help you select a treatment, whereas the dotatate PET is predictive of treatment. So if you have somebody who is positive on the dotatate scan, PRRT might work for them. Obviously, if you're also FDG avid on that scan, you might not get as much benefit because high FDG avidity just suggests a more aggressive disease. So I think dotatate PET is more important because it can help you determine treatment. Yes, if I'm deciding whether I do PRRT or chemotherapy and I have to make that decision, I might do an FDG PET in that setting. But other than that, I think dotatate PET is more important than the latter.
Okay, I think we all agree. Yes, thank you very much. Okay, Dr. Jain, we have several cardiology issues. Should my cardiologist be a carcinoid specialist?
Sorry, it was a question. Should my cardiologist be a carcinoid specialist?
Yes.
So no, I don't think your cardiologist needs to be a carcinoid specialist, and it would be pretty hard to find a cardiologist who's a carcinoid expert. There are very few of them. So most importantly, I was talking to somebody earlier about this, I think this gentleman up here, about carcinoid and heart disease and why it's so important to have a cardiologist who's a good cardiologist. Because, what we talked about was the valvular issues, the deposition, right heart failure. Those are all things that any cardiologist worth their salt should be able to take care of. And it's managed in a very similar way as somebody who has heart disease that's not related to carcinoid. So I would say as long as you have a good cardiologist who knows how to manage cardiology problems, and even more important than that, in my opinion, is a cardiologist who communicates with your oncologist and with your other doctors. You'll hear me say this multiple times because in healthcare today, it's very hard sometimes to figure out who's talking to who. With electronic medical records, it's supposed to be more easy to communicate with people, but that doesn't always happen. And so the thing that I tell all of my patients is I tell them to call me out. If you think I'm not talking to your other doctors, ask me. Make sure your cardiologist is talking to your oncologist. The thing that is most important when the cardiologist and the oncologist are working together in these cases, cardiologist needs to manage the valvular disease, manage the symptoms that you're having from your heart issues. Your oncologist needs to be able to manage your hormone levels, your serotonin levels, your medications, but there needs to be communication between the two. So that's more important than finding a carcinoid cardiologist, which really is probably there's maybe a handful in the country.
Okay, I have another point of view just to stir up a little controversy and here. I just want to talk about an anecdotal case and talk about general cardiology. I saw a patient within the last 2 or 3 months on telemedicine who wasn't able to come in person, who had massive ascites and edema and was really deteriorating rapidly from her carcinoid heart disease. She didn't know she had carcinoid heart disease, even from carcinoid syndrome. She'd been to multiple cardiologists. She was told she did not have heart failure. She had an echocardiogram, and she said she was told that everything was okay. She had seen a couple of cardiologists, and the question was whether in this shape she should get PRRT, which is always problematic when you have so much tumor and a performance status, which is not too good. And I was looking at her on the, iPad screen on a telemedicine visit, and I saw her neck veins distended up to the angle of her jaw. The jugular vein was all distended, and in the jugular vein, with every heartbeat, you could see the blood squirting up backwards, okay, a regurgitant pulse going right up that jugular vein. And I told her that she had tricuspid regurgitation with a wide open tricuspid valve. She was in severe heart failure. I don't care what the echocardiogram said. She needed another echocardiogram. She needed to see an experienced cardiologist right away who knew about this disease. She saw, our cardiologist who does this is actually the head of oncocardiology as a specialty of dealing with cardiac complications of cancer and cancer treatments, and carcinoid heart disease is one of her programs. And she indeed did a different type of technique of an echo and reviewed the previous echo, which actually did not show the tricuspid or pulmonary valve adequately because of the technical aspects of the study. So it was really an inadequate echocardiogram. It's not that it was a negative echocardiogram, it was an inadequate one. And when she had an adequate one, and she had a cardiac MR, and the next week she was in surgery, and then subsequently all her ascites and the fluid in the legs went away, she was able to get treated with PRRT, which was what we wanted to do in a much safer way. So I think there is something to be said for expertise, and have cardiologists attend multidisciplinary meetings and try to get the cardiologist that you're working with up to speed as much as possible.
Totally agree, but I don't think that needs to be a neuroendocrine cardiology specialist. So I think in this type of case, the importance, again, goes back to that communication. So you saw this and you said this is a problem, and then you contacted her, or you did the telehealth visit, but I would say that it's our responsibility to make sure that that care is being delivered. So if the cardiologist, I mean, especially, I have a lot of patients who come from underrepresented areas, they don't have access to that type of care.
Right.
They can't go to a Sloan Kettering or an MD Anderson or a Northwestern. They don't have the ability to go there. So I would say, if as an oncologist, if we're concerned that this is cardiac disease and the cardiologist is saying, no, you have no chance of having heart failure, then I think it's up to us to pick up the phone and say, hey, you don't treat carcinoid. I'm telling you this is the problem. Can you do these tests? And if it's not the right cardiologist, it might not be the right cardiologist. But I don't think everybody has access to a carcinoid expert who's a cardiologist as well. So I would say that goes back to the multidisciplinary, to the communication, to making sure that when we feel like they're not getting the proper care, because the cardiologist may have seen maybe one carcinoid heart disease in their career, then it's up to us to make sure we're going that extra step and saying, hey, this is something I see all the time. Can you maybe either talk to this expert at another institution, or could you do these tests to make sure that we're not dealing with this problem? So again, it goes back to that multidisciplinary approach and that communication and collaboration between experts.
Thank you. Okay, next one. Can a patient have mild carcinoid syndrome, or could you have symptoms only rarely or intermittently, and would you still be considered as having carcinoid syndrome if that was the case? Who would like to go first?
Yes, this is a heterogeneous disease, and the symptoms are also heterogeneous. So some patients might have mild, some patients might have severe, some patients might not have it at all. But yes, if there are mild symptoms, that means it is symptoms. Whether it is mild or moderate or severe, it depends on the severity. But yes, it is symptoms.
Okay. We actually have a bunch of cardiac questions here. Does mitral valve prolapse put NET patients at higher risk of carcinoid heart disease?
Someone else wants to answer, they totally can. I don't want to take over the microphone.
You can. So usually it is the right side of the heart that is affected, which is the tricuspid valve, and not only the valve, also the muscle and the muscle wall. But it's not like if you have a mitral valve issue, that doesn't put you at risk of tricuspid valve problems with carcinoid.
Right. And it's probably worth mentioning that there are people running around who have had a little communication between the left side of the heart and the right side of the heart called a patent foramen ovale, or PFO, that connects the upper chambers in the heart, and they go through life with this condition and don't even know it. But if you have that, then the left side of the heart valves can get affected, and you could end up with problems in the mitral valve. So actually, when we do the very first echocardiogram, it's actually a good idea to let the cardiologist understand what you're doing, and they can do what's called a bubble study, where they inject a little bit of blood with bubbles in it, and they can use that to see if it passes through an opening in the heart and see if whether or not that condition is present.
And
It's
it could
also
be the other way
possible
around, too.
it's also possible for the mitral valve to get affected if you have primary tumors that start in places like lung or ovary or other sites than the midgut. You were going to say something?
It could be the other way around, like the tricuspid valve can affect the left side of the heart, because if you have right side heart failure, it can affect the left side of the heart.
Yeah, one thing I ran out of time this afternoon I was speaking. I had a couple of slides on the fact that the majority of cases, as I mentioned, is right heart failure, but as was mentioned, patent foramen ovale, which is basically a hole between the two sides of the heart, those types of patients can develop left-sided heart failure as opposed to right-sided heart failure. The patients who have a lot of disease, so they've got a lot of tumors, if you have tumors actually in the heart, that can happen, and that can cause left-sided or right-sided heart failure. So it's much more rare to see the mitral valve or see the left side of the heart involved, but it is not impossible.
Okay, there's a question here which is, in plasma 5-HIAA, do you need to be on a special diet? Because it wasn't really clearly defined in the talks earlier whether that was necessary. So this is actually an important question. And the answer is no. You do not need to be on any special diet. You just need an overnight fast. You can get a blood test for 5-HIAA in the plasma, and that's all you need. So it's an enormous improvement in quality of life.
So we'll explain why that's important. When you do a 24-hour urine, you're collecting what the body is making over 24 hours. So you want to know how much tryptophan that gets converted to serotonin is in the diet, if it's impactful. So you can take a normal 5-HIAA, and each banana will add 3 milligrams. If anybody want to do the math, you can figure out how many bananas you're eating to, bring it down. But if your 5-HIAA is 75 milligrams per, a banana is not going to be, not be that variable. But we want you on the same thing each time we measure. We try to have you on steroid pills for probably about a week or so. If you do the urine, to kind of avoid some of those foods, particularly in research trials really emphasize the 24-hour urine. But when you do blood, you're just doing a spot level. You're not doing a whole 24-hour collection. I'll shut up.
Thank you. Okay.
But you do have to fast overnight, so sometimes people forget that, so it's sort of a dietary restriction too.
Here's a question that actually relates to the whole concept of the kind of trial designs we deal with. Why would nobody do the trial on octreotide for tumor growth control again? I made that comment, so I guess I should answer it. No, the only reason is, number one, the original trial was done at a time when no treatment was possible, and there was randomization of octreotide LAR versus placebo. You can't do a placebo-controlled trial of a somatostatin analog today, since we know somatostatin analogs work. That's the first thing. The second thing is, who in the world would pay for such a trial that would need to go on for many, many, many years to look at progression-free survival in something where we know it's not going to be so important that it's going to, in terms of results, that it's going to change clinical management. So that's the reason. It's just, I can't imagine that trial happening. Does anybody ever think it will? I don't think so. Okay. We see a lot of questions about paltusotine, which was mentioned by several people, about whether it's available for foregut, whether it's for lung, whether it's for different indications. And the problem is we have to go by the clinical trial, which is industry-sponsored at the moment, and that particular trial is being restricted to carcinoid syndrome from gastroenteropancreatic tumors. And I'm hoping that that drug will end up being approved, and other oral agents will as well, and we'll have the ability to do trials with other types of neuroendocrine cancer. But I think the very first trials are going to be on syndrome. Yes.
So when we start talking about octreotide, is it an antineoplastic? How good is it? So we've passed the placebo period, but there's a trial out there called the Camarus trial, and the Camarus trial is one that people are randomized to every other week sub-Q injection. Their blood levels are going to be more than double the control arm, which is going to be just normal, what you're getting now. So the randomization. So we're predicting that the higher levels will result in a longer progression-free survival. In other words, we'll control the tumor longer. So that's, I think, the way we'll get at this problem. There's another trial that a real-world experience in lanreotide that's just been talked about, where people on lanreotide seem to be doing better than people on octreotide in the real world. Now, this is where it's a registry trial, and they look at outcomes. So it looks like that. Did you all see this at NANETS, the poster? See, I got some heads up here. So it looks like in the real world, lanreotide is beating out octreotide LAR. What do you think? You believe that, Ed?
I do.
Okay.
Yes, I think that that's what's happening.
We published our experience when I was at Emory, and they were equal.
Yeah, they're equal.
There is a little bit of difference which wasn't statistically significant, but these are retrospective studies. There are no prospective studies,
Right.
and I don't think you will ever get a prospective
I
study.
think you're
as you
absolutely
mentioned.
right. I think in real-world utilization that lanreotide is winning out. I think that was what the issue was, but I think you're absolutely right. Okay. I'm not sure. Does everolimus really work for GI net? Personally, I think it does because I was one of the authors of the Radiant 3 and Radiant 4 trial that proved it did, but I'd love to hear what other people feel.
So, in GI nets, there were 2 studies that were done with everolimus. There was a Radiant 2 and a Radiant 4 trial. In the Radiant 2 study, patients got everolimus plus a somatostatin analog like octreotide. It was octreotide at that time only. And in that study, there was not much difference between octreotide alone or octreotide plus everolimus. There was a numerical improvement, but it didn't pass the statistical line of significance. So basically, this could have been by chance that we saw some improvement. There were a lot of flaws with that study, which were brought up later on and were thought to be the reason why we didn't see the benefit we were wanting to see, but as a statistical significant benefit. Then the Radiant 4 trial came about, which included patients who had non-functional, so patients who didn't have symptoms from their carcinoid. And those were included, and there was a clear benefit, a hazard ratio that was less than 0.5, which means about 58% improvement in the risk of cancer growing or patients dying. And this was for non-functional tumors. So if you go by the book, for patients who don't have carcinoid syndrome or symptoms from their carcinoid, everolimus is level 1 evidence it helps. If you go by practice, it is given to all GI net. I think it is effective in all GI nets.
Yes, and back to the study that was negative, the difference in survival was much higher in the everolimus arm, although it wasn't statistically significant, but we think it is clinically significant. Just to clear that issue.
That difference, which she talked about Radiant 2 and Radiant 4, that really comes down to bureaucracy. That's all it is. It's not real world. I've taken this thing apart, participated in the Radiant 2. I think you did the Radiant 4.
I did Radiant 2 as well.
I didn't do Radiant 4 because I already knew that it worked and I couldn't ethically put people on placebo. So I could not do Radiant 4.
Yeah, Radiant 2 was a statistical
Radiant 2,
fluke.
I put a lot of people on Radiant 2.
Yeah, I did too. I did all of those Radiants. And the Radiant 2 actually was a positive trial by what was called investigators' review, which meant that at the sites where the tumor was done, the radiologists declared that everolimus was working. But then, and they got it right. But then when the x-rays were sent to a central radiology review, that was supposed to be the last word on whether it was working or not working, they said it did not adequately control the cancers by just a teeny fraction of a percent off. And the reason that was when the local radiologists who work with the oncologists looked at the pictures, they knew which tumors had previously been treated with embolization and ablation and weren't actually measurable tumors that were being counted, and they were actually counting only things that were real cancer. But the central radiologist just looked at it and measured diameters and said those things were not responding the same. It was a peculiarity, and because of that, Radiant 2 then had to get replaced by Radiant 4 to do a very similar trial again, and that trial finally proved without any question that it's effective. Right, $100 million later. So it was a tragic situation. Okay, why remove gallbladders before liver-directed therapy? There's still some question about that. I think it was addressed by Dr. White. If anybody wants to attempt that, it's fine, or I could just say something about the value of having your gallbladder removed before liver-directed therapy.
Not for liver-directed therapy, but I mean, if you're going to get a surgery, any surgery to the belly and you're expecting the patient to be on lanreotide or octreotide analogs, yes, you remove electively the gallbladder because the lanreotide and the sandostatin can cause gallstones, and you don't want to end up having gallstones in the gallbladder and be symptomatic, and you don't know what's causing what, so that's why electively you remove
Right, so
the
that-
I think Dr. White had mentioned about the fact that prior instrumentation in the biliary tract, is a gallbladder, or also probably like, Whipple's or any kind of instrumentation or any diversion of the biliary tract can increase risk of complications from embolization procedures. So you have to take that into account. I
Right,
think that's probably what some.
And the other thing that I think
pointed.
she alluded to was that the artery to the gallbladder, it's called the cystic artery,
cystic
comes
artery.
off the hepatic artery as a branch. And what happens if you have not taken out the gallbladder is that a little bit of the embolic material that you are injecting into the hepatic artery could leak into the artery of the gallbladder and suddenly cut off the blood supply to your gallbladder. If the gallbladder suddenly drops dead, you have a life-threatening condition that has to be treated by immediate gallbladder removal and often results in serious infections and complications. So that if you're having your abdominal surgery for anybody with metastatic neuroendocrine tumor, you take out the gallbladder, both to prevent gallstones and complications of gallstones from octreotide and lanreotide, and secondly, because the people with liver metastases, which are the majority of the metastatic neuroendocrine tumors.
But we wouldn't take out somebody's gallbladder just to have an embolization.
No, not just for fun. Just if you're in there anyway and you're doing a surgery. If you had, if you, go on.
Yeah, I think it's a good time to then circle back to the one surgical question I think that was brought up this afternoon about whether you need to see a net specialist and what the value of seeing a net specialist is. Oh, okay. So the majority of neuroendocrine surgery is being done by liver surgeons and surgical oncologists and net surgeons. I think the value of seeing somebody who has neuroendocrine experience is that they are involved in these multidisciplinary discussions about the timing of care. That's one aspect of why determining whether or not your surgeon has experience with nets is important. The other is that surgeons who have experience with neuroendocrine, I feel, tend to be much more aggressive in terms of surgical debulking. Whereas if we are out in the community or if we are seeing surgeons who don't have that neuroendocrine experience, they may see bilateral neuroendocrine metastases and just say, no, this is not a candidate for surgery, disease has spread everywhere. And then those patients may get relegated to some other systemic therapy, and if there isn't a multidisciplinary team involved, that patient can unfortunately not undergo optimal treatment. I'd say the other aspect from a technical standpoint, the value of seeing somebody with neuroendocrine experience is that we know that these tumors tend to be pushers, not invaders. So while we are aggressive in our debulking operations, we're also very mindful of liver preservation. And as you all are now experts in the systemic treatments and local regional treatments that have been discussed, a lot of that depends on having a healthy liver. And so that is also an important part of these team-based approaches. And so you can have a wonderfully talented liver surgeon doing your operation, but if they are treating it like some of the other types of cancers that affect the liver that require negative margins and that require anatomic resections, that's just a long-winded way of saying they're taking a lot of healthy liver along with your tumor. Patients can then not be not have these other systemic treatments later available to them because they have less healthy liver.
And I will say I totally agree with that. And one way that I've allowed, so some of my patients, many of my patients are not able, like I said, to travel or to, because, I mean, luckily I'm in Chicago where there are multiple experts in the same space, but there's also insurance issues and there's all sorts of challenges that sometimes can make it very difficult for patients to get to a center that has a neuroendocrine expert. So one kind of way I've gotten around that, especially with COVID allowing for many more telehealth visits over the last couple of years. I've managed to get patients in with these types of experts with telehealth visits. And one thing that I think is really great about the NET community especially is we all communicate over email and over Zoom and over phone pretty regularly. We're on a lot of the same phone calls. So I've reached out to my NET surgeon friends outside of my own institution and presented cases to them informally. I know surgeons talk to each other as well, so I totally agree that there are definitely challenges that come with seeing somebody who may not be a NET specialist, especially if you need that type of care, which I think happens a lot. But I think that there are opportunities and ways to kind of work around that and get that expertise if you can't travel there or if you don't have the insurance coverage or whatever it might be. So it's really a good conversation to have with your oncologist and say, you know, I'd like to get the opinion of a NET specialist. What's a creative way we can make that happen? So it is, I 100% agree that it's important that we also value the expertise because NET surgeons are phenomenal, but again, they just aren't at every institution. So sometimes you have to get creative with how you get your care. And I'm going to step away so I can go catch my flight, but I want to thank you guys for letting me speak today, and I'm going to leave it to the rest of the panel.
Thank you for your participation. It was terrific. Thank you so much. Okay, we have a question here directed at Dr. Mohammed. In somebody with a functional NET, presumably with a carcinoid syndrome, how often should 5-HIAA be tested?
So there is no really a very solid recommendation how to do that. Usually I do that every 3 months with the scan. So once I got it and I know it's high, I put the patient, start them on statin, somatostatin analog or another type of treatment, and I usually get that in about 3 months with the scan, with every scan. Except if the patient have more exacerbation of their symptoms and it's getting worse, I may get it sooner than that.
Yeah, I think that sounds like an excellent idea. Keep all the tests sort of in phase with each other. Do the laboratory studies, do the imaging. If everything is okay, wait till the next 3 or 4 months when you have your next scan, and then do your laboratory studies, including 5-HIAA, do the scan. But if you have one every 2 months, one every 3.5 months, one every 5 months, you're going to get pretty mixed up and your patients will go crazy. So that's a great idea. Okay. Here's a very important question. I wish I had a really clear answer for you. What is the status of the Bemfezia pen? Now, the Bemfezia pen that was alluded to in one of the talks earlier on is a means of self-injecting octreotide with a really nice dial-up device where you have a syringe with an incredibly tiny needle in the end, comes pre-filled, and has a little wheel on it, and you just dial the number of micrograms of octreotide acetate you want to self-inject. And then it just auto-injects that particular dose into you with no problem. And if you want to have, more or double dose, you could just dial it up to a higher number or do 2 injections with this same needle poke with this little teeny thing. The drug is also totally stable at room temperature for up to 28 days, so you don't have to keep it in a refrigerator, and it looks like a pen. You could just clip it in your pocket, go around with your Bemfezia pen, and shoot up whenever you need to. It's pretty incredible. And everybody I know who had it just loved it compared to in self-injecting. But it disappeared off the market, and I do not know when it's coming back. It's probably been a year since I've seen it last.
Yeah, they got in some regulatory problems. The plant, Sun Pharma is the one that makes it. The regulatory plant, the regulatory agency, the FDA, they were not compliant, and they shut them down because they weren't being responsive to FDA inquiry. So they went over and they did an inspection, and I don't know exactly what's happening after that.
But the concept is fantastic, and I really hope for the sake of all of you that it comes back.
It's got to come back.
It's got to come back because it's really a brilliant idea. And why it got messed up after it was working so well for so long, I don't know all the details, but that's as much as I know. Thank you, Lowell. Okay. How does mitotic activity in Ki-67 correlate with prognosis and grading in lung nets?
For you.
Okay, I'll take it. I'll take it on.
You know that Dr. Wolin is a lung net specialist. I look at him as a lung net.
I hope I specialize in other kinds too. Okay, so the reason that we deal with mitotic rate and not Ki-67, which are 2 different ways of measuring the same thing, which is how fast are the cells growing, how fast are they dividing. What is the percentage of cells undergoing cell division? We call that Ki-67 when it's done by a chemical stain, and we call it mitotic count when you do it by looking under the microscope and counting mitosis cells that you see under the microscope that look like high school biology where the cells are splitting in two, and you could actually see that happen under the microscope. That's called a mitosis. The pathologists could never agree on what a cutoff number should be between grade 1 and grade 2. So they have these meetings, they sit around a table and argue, and every meeting is ended in an inconclusive argument over whether the cutoff should be 3% like in intestinal and pancreatic nets. Should it be 5%? Should it be 10%? Nobody knows an answer. So to this day, lung nets are the only site in the body which is, and maybe thymic nets, which are always graded the same way as lung, by the number of mitosis that you see under the microscope. In 10 high-powered fields of microscope, which corresponds to 2 square millimeters, you actually have to manually and very tediously count 50 fields and divide by 5, and you get the number per 10 high-powered fields, and then you say, that's a mitotic rate, and the distinction between typical carcinoid and atypical carcinoid rests entirely on that number. That's all I could say. I hope that before too long, the pathologists will agree on a cutoff for Ki-67, which we all know is a much, much more sensitive way for calculating division rate of cancer cells. Yes.
Do you think a lot of institutions now are going with the artificial intelligence and digital pathology will solve that? Because now you will have a program that can just count everything for you.
I think that's a terrific idea. This is like the kind of thing you'd think AI would solve in a day. Yeah, that's terrific. Yeah, I like that. Okay. Why do lung nets not get the attention that other primary sites do? And I hope that's changing, but in the past it's been pretty much clinical trials in neuroendocrine cancer have been largely run by GI oncologists who didn't really see that many lung nets. That's one reason. And I think the other reason is a high percentage of lung neuroendocrine tumors are not metastatic and don't need chemotherapy or systemic treatment because they're found when you go to the emergency room with a broken arm and after an accident and somebody does a chest x-ray and says, oh, you have a little nodule in your lung, and somebody takes it out before it spreads. So it's more likely to find an early incidental one than in the intestine where...
But Ipsen tried to address that with the Spinet trial.
Yes, they did. The Spinet trial was done with lanreotide
Correct.
For metastatic disease, but those patients already had metastatic disease.
Correct.
And so that was one that addressed lung specifically. The RADIANT-4 trial of everolimus specifically included lung.
So it's not totally ignored.
They're not totally ignored by any means, and everolimus was approved because of that.
Yeah.
We have a new trial that we talked about earlier of PRRT versus everolimus for lung, and other lung trials are sprouting all around, and I think that the lung population is going to catch up. But if you look at the trials in the past 10 years, there are many more for intestinal nets than for lung nets. I think that's fair to say. Any other thoughts on that? Okay. Surgical question. What features are going to improve the chances of success from surgery? Should you lose weight if you're obese? Should you eat better food? Should you exercise more? Does any of this make a difference when you're having net surgery?
All of the above. But I think that's also the case for any of these other treatments that are a hardship on the body. For surgery, wound healing requires protein, and so making sure that you're having a balanced diet. We know it's been extensively studied that obesity can lead to higher risk of wound infections, hernia development. There has been extensive studies on obesity and cancer diagnoses, and so certainly having a healthy lifestyle helps you not only recover from a major operation for your neuroendocrine tumor, but also with your survival and fitness to undergo many of these other treatments. Was there a second part to that question? Oh, I would say, of course, I'm sure it goes without saying also smoking is something that, especially in East Tennessee, we have to counsel our patients on smoking cessation in anticipation of surgery.
Right. Okay, thank you. The next question, why don't we let Lowell start on this one, Dr. Anthony, and then other people can chime in. Here's the question. How does the pathologist determine the primary tumor site?
The pathologist?
Yeah.
Well, what the pathologist does is they write a report on what's in front of them. So if a biopsy of a liver is in front of them, they don't know where the primary is. So what they'll say is consistent with an intestinal primary or consistent with a lung or pancreas. So they are part of the staging system. So they do they can do the T and the N. They rarely do the M, and they don't assign the primary site. So it takes a team to do the staging, the American Joint Commission on Cancer Staging, AJCC, and the managing physician works with the pathologist, works with the radiologist, and the managing physician is probably the best one to stage the patient to determine what the primary is, determine where the disease is. So
Right. And sometimes pathology can give a clue.
it can. I mean, particularly if the terminal ileum is sitting in front of them, they see the primary in the ileum, and they say, "Hey, this is an ileal primary."
There's some immunohistochemistry markers.
It's not a metastatic lesion to the ileum. If it looks like it's formed in the submucosa, it's invaded, so they can call the primary site if it's,
Right, and if you have a biopsy of a site like liver, the pathologist can never guarantee where it's from.
Or a lymph node.
Or a lymph node, they can't guarantee where it's from, but if you have an immunohistochemistry for something called TTF1, it's likely to be lung, but it certainly doesn't prove lung. CDX2 is another marker that is common in pancreas. And they have various markers like that that can be done by immunohistochemistry that give a clue, but never an absolute diagnosis. So it always has to be just taken into consideration with the whole picture. Sometimes we get information from genomic testing. You might get a hint of where the cancer might have originated from the gene mutation patterns. And interestingly, if you've already done really good imaging of the abdomen and pelvis, and you've done endoscopic ultrasound of the pancreas, and you've done everything, and you don't see a primary tumor, it usually means that it started in the small intestine, especially if there's a mesenteric mass. But if you can't find a primary in the small intestine, that's where it usually is. We did a study when I was at Cedars-Sinai in California with double balloon push enteroscopy on this population with liver metastases and unknown primary, and 85% had an identifiable small intestine primary on double balloon push enteroscopy. It's not a procedure that everybody knows how to do or has the time to do, but it is a procedure which is amazingly accurate in finding primaries, and we found primaries as small as 1 millimeter, just like little teeny weeny baby primaries with big liver metastases. And these were biopsy-proven primary tumors. So I think that we really have to just put the whole clinical situation in perspective. Yes, you were going to say something.
No, agreeing completely. I was just saying that, push enteroscopies have found but our gastroenterologists always are, worried about the risk of perforations and other complications from these procedures. So it's always, it has to be done on an individual basis in general.
Thank you. In the interest of time, do we need to wrap up now and then just address other questions individually later? I think we could. We have 2 or 3 more questions if we have time for it. Sure. Is that okay? Okay, here's one. Can high-grade neuroendocrine tumors develop carcinoid syndrome? And if you have a high-grade neuroendocrine tumor, does the carcinoid syndrome come faster and more aggressively because it's high-grade? Well, that's a question.
So I'm going to start and everyone else can chime in. High-grade neuroendocrine neoplasms are of 2 types. There's the poorly differentiated high-grade, and then there's the well-differentiated high-grade. It's just basically how they look under the microscope. So the grade 3 or high-grade neuroendocrine tumors, which were like well-differentiated, they just look like regular neuroendocrine tumors, but just divide faster, can be associated with carcinoid syndrome. Are sometimes, have patients like that. The poorly differentiated neuroendocrine carcinomas, which are the high-grade cancers, but also look very different than regular neuroendocrine cells. They're much more, early and much more poorly differentiated. Those cancers rarely have carcinoid syndrome because these are so degenerated cells that they forget that these are of the neuroendocrine lineage and have to secrete hormones and things like that. Having said that, never say never. I have a high-grade cancer who's had syndrome, but typically higher-grade cancers tend to have lesser incidence of carcinoid syndrome than the lower grade cancers, just because they are devoting all the energy into grow and divide rather than secrete the hormones. Think of it that way.
Okay, thank you. Maybe one or two more questions. Are there any liver-directed therapies for somebody who's had a Whipple surgery?
Yes, Y90 beads can be given. Maybe some risks for infection, but usually the Y90, it's different. It's not really an embolization. So that's about all we would recommend. I've done it a few times and gotten away with it.
And then there was a question whether ablation is just as dangerous as embolization.
So after a Whipple, you really have to be careful.
Right. Because you really can get life-threatening infections.
Yes,
Liver
ascending
abscesses.
cholangitis.
Yes.
Is
And it
our
can
real
be,
concern.
It can be deadly. So we have to be careful. But okay, and one last question, which I think Lowell would like. Is the new study of tripene open for patients with lung primaries?
For lung, I think it's phase 2 that'll open up for Salman's trial. Is Alman here? He's looking at sometime latter part of January. But it's not just for lung, though.
No,
I think
it's for
it's the phase 2. They'll open it up.
Right.
Yeah.
Okay, so a few more months, stay tuned. Okay, I think that should do it for right now. Thank you very much. Thanks to the whole panel. Thanks to the Womans. Thanks to all of you for being here.